Alrighty. Hello, everyone. First of all, I'd like to apologize for the delay in recording and posting these lectures. It's been kind of hectic at the hospital, picking up shifts and all that stuff with the whole coronavirus stuff going on. So, I'd like to start off with a couple of updates, I guess. All of your homework, the remaining homework that you have, this includes your workbook, your online homework. There's a couple of additional assignments that I have posted online. All of that stuff will be due the day we come back after this all blows over. So your first day back for lab. Your last exam will also be that day. I tried to figure out how I could go about posting it online, and I'd rather be there while you guys are taking it. So your exam and all your homework will be the day we come back. So I have no idea when that's going to be, hopefully soon, but just prepare for that. Your last 4 labs will be a review of venipuncture and procedures and all that stuff, and then we're going to also do your competencies. And your competencies are a pretty big chunk of your grade. They're basically your exams for the lab portion of the class, so we'll complete those. I would like to say that on your last exam that you are going to be having a large chunk of the written portion of the exam is going to be order of draw stuff, because with this break that we have in the class, and I just want to make sure that you guys really know that information because it is the most important, as I said before. So make sure you're not only studying chapters 9, 10, 12, and 13, but also your order of draw review on that, because that will be a large chunk of the next exam as well. So I'll probably have all of your multiple choice questions will be chapters 9, 10, 12, and 13, but a large chunk of your short answer questions are going to be order of draw, departments, tests, that kind of stuff. As far as your externship requirements, we're going to talk about that during your final labs when we get back. So we'll have you prepared for your externship when it's time to go back to that. Okay, with that being said, I have a really hard time talking at a computer screen for 2 hours. So I may be breaking your lectures up into hour segments just for my own sanity. Like I said, this isn't exactly what I expected our class to be. I don't exactly like teaching this way. I like to see your facial expressions and have some interaction with you guys while I'm teaching, but we're doing what we can during this crisis. So, chapter 9 is going to be on pre-examination and pre-analytical considerations. This is basically everything that happens before the specimens are analyzed and results are obtained. So it's your job to ensure that there's no errors during this phase. And this chapter goes into some of the possible pre-analytical or pre-examination errors that could occur and how to prevent them. But chapter 12 is going to go into a lot more depth on sources of pre-analytical error and how you can prevent them. So just keep that in mind. Okay, so like I said, the pre-analytical phase of testing begins the minute a test is ordered, so the minute a physician writes a test down on a requisition, and it ends as soon as the tech begins the testing phase. So your skills that you'll need as a phlebotomist are technical skills to perform the blood draw accurately. So this is going to be our venipuncture procedures that we've talked about in Chapter 8 and that you've gone over with Justin in lab. And then the ability to recognize pre-analytical factors and address them. So if you are going to draw a patient and they have a big old bruise on their arm, are you going to want to draw from that spot, or are you maybe going to want to go somewhere else? We're going to delve into that more, but that's basically like what they're saying is the ability of the phlebotomist to observe certain things and avoid them. Okay, I'm just going to read through this because we're going to go into more depth throughout the presentation. So We're going to go over physiologic variables, problem venipuncture sites, types of vascular access devices. So I had mentioned this in a previous lecture about IVs and PICC lines, ports, central venous catheters, all that kind of stuff. We're gonna go through that in this chapter. It's probably one of the more confusing aspects of the material that I'll be teaching you in this class, because it's more in line with what a nurse should know, but it is important for you guys to know vascular access devices too, because that is a way to draw blood from a patient. We're also going to go over complications and certain conditions that patients may have, and what those conditions mean for us drawing blood. We're going to go over procedural errors, specimen quality issues. So say the draw is too short, you don't have enough blood in a light blue top, so you don't meet your 9:1 ratio. That would be a quality issue. The tech would reject it, stuff like that. And then troubleshooting failed venipunctures. So if you poke someone and put the tube on and there's no blood flowing into the tube, how can we fix that draw without having to poke again? And if we are unable to fix that draw, when we know, we should just discontinue and start a new fresh poke. Okay, so the first thing we're going to talk about is reference ranges, also called intervals. So I'm gonna, when I go through these presentations, I'm gonna just read what's on the PowerPoint slide, and then I'll go into more depth. This just helps me with teaching. So, test, confirm health or screen, diagnose and monitor disease. Test results are compared with specimens of healthy people. They consist of a range of values with high and low limits, and most often are based on healthy fasting people. So basically what this slide is saying is, in order for a doctor to evaluate a person's condition based on their blood test results, they need to have a range of values in order to compare those results with. So their reference ranges are basically just normal values for each individual blood test. So the physician has something to compare the test results of the individual they're testing with. They're taken from normal. They say normal, which means healthy individuals that are fasting. And the reason there's a range rather than just like one value is because even healthy people have differences in levels. So they create a range of, like, a healthy range of levels. Another thing to note is that there are different reference ranges for people with known health conditions, such as diabetes. There's different reference ranges for males than there is for females. There's different reference ranges for children than there are for geriatric patients, which are elderly patients. So there's many different reference ranges depending on medical condition and age and stuff like that. So we'll go into those factors now. Oh, something else that I do want to say about reference ranges, though, is that doctors will not only compare the results to the normal reference ranges, but they'll also compare the results of a certain individual with previous tests on that same individual. So you might, like, your normal might be just barely out of the normal reference range. But if you consistently show that level in all of your previous blood tests, a doctor might not be as concerned about it because that's like your normal. And then with that being said, they will also compare those results with previous results if they're looking to see if a treatment is working. So say a patient comes into the ER with a really, really low hemoglobin level and they have to receive a blood transfusion to get their hemoglobin back up. A doctor is going to order a hemoglobin blood test every 3 or 4 hours just to make sure that the hemoglobin is increasing with the treatment. So they not only use normal reference ranges, but they use reference ranges or they reference previous tests on the same individuals in order to monitor treatment. Okay, basal state is another interesting one. It's similar to fasting. So the definition is the resting state of the body in the early morning after fasting 12 hours. A basal state specimen is ideal for establishing reference ranges on inpatients. So like I said, if they're going to look back at previous results of patients that are in the hospital to see about treatment, how treatment's working and that kind of stuff to make sure that their condition is improving, this is ideal for establishing that individual's reference ranges. Certain things like diet, exercise, and other easily controlled things can have results on tests. Or the results of tests. So the reason that it's ideal for inpatients is because these factors can be easily controlled on inpatients. They're in the hospital and a nurse is right next to them, making sure that they're not eating or drinking or getting up and moving around too much, etc. So with that being said, would an outpatient specimen be considered a basal state specimen? No. An outpatient specimen would simply be considered a fasting specimen because those factors that can influence results like diet and exercise, etc., cannot be controlled in an outpatient unless a nurse goes home with you or a doctor goes home with you and is like keeping an eye on you. So that's why they say they're ideal for establishing reference ranges on inpatients, not outpatients. So some of those factors are influenced by age, gender, and certain conditions of the body. So we're going to go over some of those physiological variables. I'm not going to spend too much time on this. I don't expect you guys to memorize this. I just want you to know that there are certain physiological variables that can affect reference ranges or test results on certain people, okay? So I have page 275 written in my notes. Oh, yeah, okay. That's just for the, okay, sorry. So I'm going to go over just a couple examples. I won't go through the whole chart here, but your pages 273 through, looks like 278, it goes into more depth on all of these things if you'd like to read in more depth on it. But so your age has an effect on certain things like your red blood cells, white blood cells, and creatinine clearance. So your red blood cells and white blood cells are actually a lot higher in newborns than they are in older people. Your kidney function decreases with age. So that's another example. Lipids. So if you have a high level of lipids, which is considered with diet would be where this would come into effect. If you have eaten a diet high in, or if you've eaten meals high in fat content or high in cholesterol, that kind of stuff, you'll have a high lipid level. And with a high lipid level, you'll end up getting what's called a lipemic specimen. So I think your book talks about this a little bit. Yeah, so on page 274 in your book, figure 9.1, it actually shows you what a lipemic specimen will look like. So basically, with a lipemic specimen, the serum or plasma is going to appear milky or cloudy. And that can actually have an effect on the results of certain chemistry tests. So that is definitely something important to notice. I wish that I could be in class with you guys and show you. I have a picture of a extremely lipemic specimen, like to the point where they couldn't even test it. It looked like milk. It was white and cloudy. The serum was white and cloudy. It looked like somebody poured milk into that tube. Maybe you know what I'm going to do? I'm going to upload it to Moodle. I'm going to upload that picture to Moodle so that you guys can actually see it. It's pretty interesting. It's pretty cool looking. But anyways, that is indicative of a diet high in fats, because lipids are fats, right? So, I think we might go into that more in depth later in this chapter, but anyways. So another thing is drug therapy. The next one down. My mouse will move. Drug therapy. So there are so many different drugs that have so many different effects on test results. I'm not going to go into much depth. I'm just going to give you one example. So chemotherapy that will actually decrease a patient's white blood cells and platelets. I lied. I'm going to give you 2 examples. So chemotherapy is one. It will decrease a patient's white blood cells and platelets. I've actually had a lot of techs that will come up to me and ask me, hey, that patient that you drew in room 7, do you know if they're on chemo by chance? Because their white blood cells are so low that it's like scary. And so, I look into their chart. Oh, yep, they are on chemo. Okay, that makes sense. That's a relief. Another drug therapy, and this would be the one that we are most concerned with as phlebotomists, so keep this one in mind, is anticoagulants or blood thinners. Why do you think we would be concerned with anticoagulants or blood thinners? So if a patient is on an anticoagulant or a blood thinner, their blood is obviously going to be thinner, and so the bleeding is going to continue for a lot longer period of time than a normal individual that's not on blood thinners because their blood's not clotting as quickly. So when we draw a patient that's on blood thinners, and I always ask, every time I draw somebody, I ask them as soon as I pull the needle out, are you on blood thinners? Do you take an aspirin a day? And if they say yes, then I make sure that I hold pressure on that site for a little bit longer than I would with other people, and I always check to make sure that they have stopped bleeding rather, before I wrap them up with the Coban or put tape on their gauze. And this is because when I was on externship, one of their new phlebotomists did not check that the blood had stopped, or the puncture site had stopped bleeding before they wrapped a patient that was on blood thinners up. And about 2 minutes later, the patient came back with blood running down his arm. He had blood completely through the gauze, completely through the Coban, and had soaked his shirt with blood because that phlebotomist did not make sure that he had stopped bleeding before he left. Something else that I would like to say with this is that if you are holding pressure on a blood draw site, for longer than 5 minutes and that patient is still bleeding profusely, there's something wrong, and you should let their doctor know or nurse know, or if they're an outpatient, call their doctor, because their blood thinner levels are not right. They should not be bleeding that much for that long, so their blood is too thin in that situation. So yeah, we are most concerned as far as drug therapy with blood thinners or what we call anticoagulants, so like warfarin, those kind of things. I said before, sex has an effect on reference ranges, so you're going to have different normal ranges for men than you will for women. You will not need to know the reference ranges, just so that you guys know. When you go into a patient's chart, the normal ranges will be listed, and if they fall outside of those normal ranges, it will tell you, okay? And there's, not to confuse you more, but there's the normal reference ranges. If they're just barely outside of those reference ranges, it doesn't necessarily mean the doctor needs to be concerned. But there's also a reference range for what we call critical values, where if they're outside of a certain range, if they're outside of that critical range, then it means that, okay, there's something going on, they need immediate assistance. And in that case, if they go into a critical range, in their chart, it will actually appear red with like an exclamation point next to it, and it's actually your job, if a lab tech comes up to you and hands you a piece of paper saying, this patient has a critical value of white blood cells, blah, 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 you actually have to call the doctor or whoever is listed to call, and let them know that they have a critical value. In a lot of cases, when that happens, like say you have a critical value on an outpatient, a lot of times when you call the doctor, you're gonna see them in the ER in about an hour, because they're gonna need some type of assistance. So keep that in mind. So you have your normal range, and then a little bit further beyond that, you've got a critical range. And if they fall between the normal range and the critical range, it might not be cause for alarm, but if they fall outside of that critical range, it's definitely a cause for treatment. They need treatment, and usually pretty quickly. So smoking is another one that I would like to mention. So it says here smoking, it'll increase cholesterol, cortisol, glucose, etc. But what I want to state about smokers is a lot of smokers have impaired circulation to their fingertips. So in chapter 10, which is the next chapter, we talk about capillary punctures. So if you cannot get blood out of a vein, or it's a really tough draw, or if you're drawing from a baby, stuff like that, we do what's called a capillary puncture, where we just puncture the skin and then the blood kind of just drips out of the fingertip or the heel. But for smokers that have impaired circulation to their fingertips, this makes collecting a capillary specimen a lot more difficult. And I will mention this again in chapter 10 in case you guys forget. But so collecting a capillary specimen from smokers can be more difficult because they have impaired circulation to their fingers, which means they're not going to bleed as well. And so it's the blood is probably going to clot quicker because you're going to probably be trying to squeeze it out of the finger. It makes it a lot more difficult. So if a patient is a smoker, keep that in mind. Stress is another thing, environmental factors. So hemoconcentration, I am going to go into more depth on what hemoconcentration is later in this chapter. But basically hemoconcentration, this can happen in patients that are dehydrated, or if you leave a tourniquet on for too long. Basically, the cellular components of your blood are in higher proportion than the liquid components of your blood. So think about if you're dehydrated, you don't have a lot of liquid in your bloodstream. Not only are dehydrated patients harder to draw, but their results can be erroneous because of that hemoconcentration, where the cellular components are in a much higher concentration than the liquid components of the blood. Hopefully that makes sense. If you guys have any questions, please do not hesitate to text me, email me, any way you want to reach out, go for it. Okay, jaundice. I'm going to take a quick drink here. Hold on. Sorry. Jaundice, I'm sure you guys have heard of a lot of times in babies or patients or people that have liver disease. It's also called icterus. So that's ICTERUS, which is a condition characterized by increased bilirubin levels. Does anybody know what bilirubin is? So basically, bilirubin is a yellow bile product. It's created when there's a high destruction of red blood cells or breakdown of hemoglobin. So it's basically like a byproduct of the destruction of red blood cells and hemoglobin, which is a natural process in your body. But when it happens at high levels, such as in patients that have liver disease, where their liver is not functioning as well, it can overproduce bilirubin. Another form is in newborns that they're not. It could be caused by a high destruction of red blood cells, but generally in newborns, it's just that their body doesn't know how to release or get rid of the bilirubin properly yet. So that's why they put them under the Billy lights, they call them, or have you stick them in a window and get the light, because the light is actually what helps your body break down bilirubin or get rid of it. Don't ask me the whole, like, to explain that process, because I'm not really sure how light does it, but that's why we have to protect a bilirubin specimen from light, because light helps the bilirubin break down. So if we transport a specimen to the lab not protected from light, the results might not be accurate because the light in the process of transporting it to the specimen can have helped the bilirubin break down. But anyways, so an icteric specimen on page 274, it's the middle one. It looks a lot, the serum or plasma looks a lot darker yellow, sometimes orange looking, and this can also interfere with chemistry tests. So not only does your lipemic specimen interfere with chemistry tests, but your icteric specimen can also interfere with chemistry tests. trying to think of anything else I want to say about this. I don't think there's anything else I really want to say about this. Has anyone seen like a jaundiced looking baby or person? I've drawn quite a few babies with jaundice, and I've drawn one person that I was shocked at how yellow they looked. Like you will be able to tell if a person is jaundiced for sure. And if when that happens, if I'm drawing somebody that looks yellow, I mean, it's only happened to me a couple of times, but I grab an extra PST and put it, protect it from light, just in case they decide, oh yeah, I'm going to order a bilirubin, because that is probably going to happen. Okay, burns, scars, and tattoos. So I'm going to start off by just reading this again. So veins are difficult to palpate. They may have impaired circulation. New burns are painful. Tattoos may be more susceptible to infection, and the dyes may interfere with test results. Damaged veins, sclerosed or hardened. Sclerosed can also mean scar tissue, buildup of scar tissue on the vein. Thrombosed is clotted. These veins can be difficult to puncture and yield erroneous results. Okay, so I'm going to start off talking about tattoos. Many patients that you draw with tattoos really value their tattoos, and I understand that for sure. They'll ask you to draw elsewhere if they don't want to scar or damage their tattoo. Something else that I would like to say about tattoos is they may mask other conditions. So a tattoo might be covering up a bruise or a rash or some other type of problem on the skin, on the surface of the skin that you cannot see. So it's usually best to, even if they don't ask you to draw somewhere else, it's usually best to try to draw somewhere else. However, there are certain patients that you don't really have a choice but to draw where their tattoos are. Example, patients that have like a full sleeve. I had a patient that came in, she literally had tattoos just on her AC and the backs of her hands. Like, it's almost like she put them there on purpose. But, I mean, you're going to see all sorts of different stuff. So I always try to draw somewhere other than on a tattoo, because not only that, but like it says in the slide, they're more susceptible to infection. And the dyes that are in the tattoo could interfere with test results. Not normally, but it is a possibility. So try to avoid tattoos if you can. We had one patient actually that came into the hospital, and they were in the hospital for, I want to say 2 weeks. They had sepsis. So we had to draw this person multiple times a day, every day, and there was actually a spot on his tattoo that it was like a break. It was like the eyeball of a skull. Like, so he had like a skull and like a right in his AC area, and the vein actually ran right through the eyeball of the skull, so there was no dye right in the eyeball, and that's where everyone was poking him, right in the eyeball of that skull over and over again. So sorry, that's just one example I wanted to mention. Let's talk about burns now. Burns are extremely painful, extremely susceptible to infection, because it's just like open, oozing skin. So do not ever, under no circumstance, draw from a fresh burn or even a scabbed up burn. It's just really painful for the patient. And not only that, I don't know how you're going to feel a vein through a scab. And I don't think a burned patient will let you poke around on their burn. So you're going to have to get clever with burn victims. Scars, if they have scars, you can poke through a scar, but I will tell you this, it's going to be way more painful for the patient. It's going to be a lot more difficult for you to get blood from a vein that is scarred up or through scar tissue. Scar tissue is hard and cord-like. The needle does not puncture through it as well. It's just, I don't know. You'll know when you poke a scar. You will know. And there are some patients that are, like IV drug users where they've just used up all of their veins. All of their veins are sclerosed and scarred up. Those are the most difficult people to draw from, are IV drug users. We had a patient come in a while ago. It's probably like a year ago. And he had gone to 3 different clinics, 3 different hospitals, trying to get blood work done, and none of the phlebotomists were able to get blood from him because he had completely annihilated his veins with previous drug use. And I think we had 5 people, 5 of us tried multiple times on this patient before we got just barely enough to do the testing that we needed to. So those are going to be the most difficult, I would say, patients to probably draw from are IV drug users, just because of how sclerosed and hardened their veins, and they track up the entire length of the vein. Like it's not easy. It is not easy to get blood from them. Not only that, but if you draw from a sclerosed vein, a lot of times the flow to through the needle is much slower. The vein might be a little more collapsed because of that scar tissue pushing down on the vein or encasing the vein in some cases. So if the blood is flowing through your needle really slowly, what is that? What can that cause? It can cause erroneous results because of the impaired flow of blood, because it could cause oh my gosh, the word is slipping my mind. I don't know why I can't think of this word right now. We're going to move on, but scars can be caused not only from IV drug use, it can be caused from many venipunctures in the same area. I've had patients come in and say, this is my good spot. Everyone pokes me here and I feel, and it's just hard as a rock from the scar tissue buildup on that spot. And, in that situation, I might ask them if it's okay if I go somewhere else, because like I said, if you don't feel comfortable poking someone somewhere, you're not 100% confident, don't go there, because chances are you're going to miss. So I always, if I feel like a hard spot, I'll either try to kind of feel down the vein and see if there's a more feasible spot to go that's not as sclerosed and hardened, and poke below the scar tissue or just above the scar tissue, or I'll just go completely to a different location if I feel more comfortable with it. So, oops, I ripped my page. Okay, and hemolyzed was the word I was looking for. I don't know why I could not think of that. So, if you draw through scar tissue and the blood is flowing slowly, there's a much greater risk of hemolysis of the specimen, which means that the red blood cells are lysed or broken. So, now we can move on. I feel better. Okay. Other problem sites include edemas or edematous tissue or hematomas. Does anybody know what an edema or edema means? It's very, very difficult to draw from a patient that has swelling, which is another word for edema. So an edema is a swelling caused by abnormal accumulation of fluid in your tissues. This could be due to IV fluid that's leaking and infiltrating the surrounding tissue. It could also be due to the fact that they've had lymph nodes removed on that side, so they don't have the normal bodily filtration system that everyone else does. So with that lack of lymph nodes, they get a higher accumulation of fluid tissue. Good Lord, I can speak today. And this fluid tissue can actually contaminate your blood or cause erroneous results. It also makes it much, much harder to locate veins. So we're going to talk more about having lymph nodes removed in a little bit here. But I do want to say, if a patient has had lymph nodes removed on a side, which can cause swelling on that side, you will not draw from that side. They have a higher risk of getting infection because they don't have those lymph nodes to filter the blood and filter the tissue fluids. So that's why we don't draw from a side that has had lymph nodes removed. We'll talk more about that in a couple of slides here, but I just wanted to mention that while we were here. And I also want to notice that you as the phlebotomist are going to probably be the people that are waking the patients up in the morning, because we start our draws. Some places start their draws at like 4 a.m. We start our draws at 5 usually. And that is because we want to have their blood drawn back to the lab and the test resulted before the doctors come in for their morning round. So the doctors can analyze the blood results before they go in and talk with the patient and decide what they're going to do for treatment, or how they're going to diagnose a patient before they go in and talk with them for the day. So that's why it's so important that we start early in the morning. But I will say that you are probably going to be the first person that will notice things, not only edema, hematomas. I just the other day went in to draw a patient in the morning, woke him up, and he was bleeding from his mouth. So I had to let a nurse know. There was one instance I walked into the room and I noticed that a patient's fingertips and lips were blue. Obviously not a good sign, means that she's not getting enough oxygen. So I went and let the nurse know, and she actually ended up passing away as I was telling the nurse that her fingertips and mouth was blue. So it's very important that you are not just going in there, drawing their blood and getting out, but if you notice things, that you're letting someone know, because you are the first person to see them in the morning most of the time. Something else that I noticed when I went in just last week, I went in to draw a patient, and she had an IV on one arm, so I went to the other arm, and she had this big, puffy, swollen area around a previous IV site. I touched it. It was hot to the touch. So what did I do? What would you guys do if a patient had symptoms of an infection? I grabbed a set of blood cultures just to be safe. And I also went and let her nurse know. And the nurse let the doctor know. And 2 hours later, the doctor ordered 2 sets of blood cultures on that patient. So guess what? I didn't have to go back up there and poke her 2 more times. I only had to poke her 1 more time for the second set. So, see, it's not necessarily our job to notice these things or to think proactively, but if you want to be a really good phlebotomist, it is essential that you do these things and always be looking out for the patient and thinking of the patient. Imagine that you are in their shoes. It is so important for you to have empathy, not just sympathy, feeling bad for a patient, and having empathy is to actually physically feel what they're going through. So put yourself in their shoes, put yourself in that hospital bed. Do you want to be poked 1,000,000 times when you're in there? Probably not. So just think proactively as a phlebotomist. If you notice certain things that you know aren't right, let someone know. Okay, so back to the edema situation. I'm sorry I went off on a little rant there. So not only is it hard to find the veins, but their skin is really thin and fragile when you poke through it, so it doesn't heal as quickly. I've had to poke through a very edematous hand before in a patient, and the tissue fluid actually leaks out of the puncture site after you draw their blood. So their vein, the hole in the vein might clot up rather quickly, but that puncture through their skin, it might actually continue to ooze that tissue fluid for hours after you poked them. So keep that in mind, that their skin is thin, fragile, and it doesn't heal as quickly in those edematous sites. And also that tissue fluid contamination can alter the composition of their blood, so it can affect test results There are certain situations, though, where both arms are completely swelled right up with certain conditions, and you don't have a choice but to puncture through an edematous site. So one trick that I learned from another phlebotomist that works at the hospital is that in a really swollen site, if you take a bunch of if you take a bunch of alcohol swabs and you apply those alcohol swabs over top of the site that you're looking at, and you kind of push down on it, and almost like it's part the fluid that's in the skin by pressing down. It sometimes makes it a little bit easier to find veins, but I would say drawing through a swollen limb is really, really difficult. So keep that in mind. Hematomas. So a hematoma, I'm sure we all know what a hematoma is. It's a swelling or mass of blood under the skin, and it is caused by blood leaking from a vessel. It doesn't necessarily have to be during venipuncture. It could be leaking from a vessel after venipuncture if you don't apply adequate pressure to the site and ensure that the blood has stopped before wrapping them. The blood can continue to leak from that vessel and create a hematoma. That's why it's really important that you're checking to make sure that it's just a pinprick bleed before you wrap them or tape them. This can be really painful for the patient, and if you try to draw through a hematoma, it can actually contaminate the blood sample. Or obstruct blood flow, it says. Obstruct blood flow. I don't know how it would obstruct blood flow. But anyways, I want to say that we draw at the nursing homes, and they actually require us to keep track of where we draw their patients from and then record it in a log before we leave. So this actually enables them to keep track of any bruising on their patients. So if there's a random bruise and they don't know where it came from, and they look in our log and say, oh, okay, they just had a blood draw, that's exactly where they drew the blood from. That's why they have that bruise there. This is a really helpful tool for them to keep track of bruising and stuff like that on their patients. Anything else I want to say about a hematoma? I'm going to go to the next slide. Okay, so here's an example of a really bad hematoma, okay? Sometimes small bruises are unavoidable, rather. So for patients that are on blood thinners, a lot of times you're going to leave a bruise. No matter what you do, even if you put pressure on, you can see a bruise forming as soon as you poke them. Sometimes they're unavoidable. However, if you are drawing someone and you start seeing their vein puff up and a hematoma start forming, you will be able to tell. Trust me, you will be able to tell. You are going to immediately discontinue that draw and put firm pressure on that site, okay? A lot of phlebotomists will not do this. If it's a really, really difficult draw and they see a hematoma start forming, they are going to just collect as much as they can before the hematoma gets too bad. No. Immediately, as soon as you see a hematoma start forming, even if it's on a hard patient, a hard draw, you're going to discontinue the draw and put firm pressure on that site, because this could happen if you don't. This is a result of a hematoma from a blood draw. And so when a hematoma forms, it's a big pool of blood under the skin, right? Gravity is going to work against you in that. So this blood draw could have been up here, and the blood slowly migrated down here with gravity and consumed this entire section of that patient's arm. And I'm sure this is very painful for that patient. I'm assuming this patient was probably on blood thinners too, because that is a pretty big hematoma. Trying to think of. So if that happens to you, where you blow their vein and you see a hematoma start forming and you discontinue the draw, explain to them, I'm really sorry, I just blew your vein. You're probably going to have a pretty big bruise from that. It might not hurt them initially, but it can cause pain later on because it is a bruise under your skin. So I always let my patient know and you know what happens to everybody. Some people have very thin, fragile veins. If you misinterpret the size of the vein and you use too big of a needle and it blows the vein, they're going to get a bruise. It's sometimes, like I said, is unavoidable, but just make sure that you're keeping your patient in the loop and letting them know, I just bruised you. I'm really sorry. It was not my intention. Be respectful of them 100%. And a lot of times when you are open and honest with them about that kind of stuff, they're going to respect you a lot more. So here are some other venipuncture or hematomas that are resulting from venipuncture. This is kind of one of the more common ones you'll see. This is most likely resulting from not applying adequate pressure or allowing the bleeding to stop before wrapping the site. These aren't going to be too much of a problem to draw through. Excuse me. But I suggest trying to poke above or below this site, this hematoma. If you absolutely cannot, it's probably not going to be that big of a deal. But a hematoma like this, you're not going to want to poke through. It's going to be really painful for them. It can cause negative test results. So don't poke through a hematoma like this. And this would probably be a result of a phlebotomist poking, seeing a hematoma forming, and continuing the draw. This is more likely a result of not applying adequate pressure afterwards, or maybe they started getting a hematoma and immediately discontinued the draw. This would be more likely the bruise you'll see with that. You don't want to cause this on anyone, trust me. Anything else I want to say about that? No. Okay. So I'm probably going to, at the vascular access devices, I will start a new video just so that I'm going to try to keep the videos under an hour because I don't think YouTube will let me upload videos longer than an hour with my account. So we talked about the removal of lymph nodes, and if a patient has had lymph nodes removed on a side of their body, we will not draw from that side because they have a greater risk of infection, and we do not want to be the cause of someone getting sepsis or any sort of infection. It's also going to be more difficult if they've had lymph nodes removed, like I said, because they're probably going to be a little bit more swollen on that side. So another thing is if they've had a mastectomy, which is the surgical removal of a breast, we also are not going to be drawing on that side because commonly with a mastectomy, they remove the lymph nodes on that side as well. So their lymph flow is obstructed with the removal of those lymph nodes. Like I said, they can be more swollen on that side. Infection is going to be a lot more likely. So we don't want to puncture the skin in any way. We don't want to cause an opening for an infection to start. Applying a tourniquet or blood pressure cuff can also cause injury. Let's see. So if they are not swollen or if they're just slightly swollen, putting the tourniquet around or the blood pressure cuff can actually cause secondary lymphedema or swelling to the extremity by that pressure. And they would consider that like a source of trauma almost to that arm. And it can also change the composition of their blood with that increased lymph fluid on that side. So never, 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 never perform venipuncture on a side that has had mastectomy or any type of lymph node removal, okay? Never. And that will be on your exam, okay? Never perform a venipuncture on a side that has had a mastectomy or lymph node removal. So, if a patient has had a double mastectomy, what are we going to do? There's really not a good answer to this. You're just going to choose a side. I think it goes into more depth on this in your book. Let's see. When a mastectomy has been performed on both sides or there is no suitable site other than an arm on a mastectomy side, the patient's physician must be consulted and written permission to draw from the arm on a mastectomy side must be obtained. So if they've had a double mastectomy, most likely they're going to have a note from their physician telling you which side to draw from. Or maybe they're going to have a note saying, draw from my foot, draw from my leg. So there's really, like I said, no good answer to a double mastectomy other than a doctor's note telling you basically exactly where to draw from. Okay. Obesity is another potential complication of blood draw. So the biggest problem with patients that are obese is, first of all, putting the tourniquet on them. Tourniquets have a tendency to roll and pinch their skin. It's a lot more painful for them. So a lot of places have bariatric tourniquets. We have like a roll. So if a patient's like really obese, you can actually cut it to the size that you want. However, we don't carry them on our trays. So a lot of the times what I'll do when I go into a room and a patient is too big for my tourniquet or the tourniquet's rolling and it's just causing all sorts of issues, I will put a blood pressure cuff on them and just pump up a blood pressure cuff and use that as a tourniquet. That's a lot less painful for them. It's a lot easier for me rather than running all the way back down to the lab to get the bariatric size tourniquets that I don't carry on my tray. I just use the blood pressure cuff and that works really well for me. It's up to you what you want to use. You could put a towel underneath the tourniquet to help with the pinching of the skin or the rolling of the tourniquet. But some patients, it's really difficult to get a tourniquet around their arm. Their veins are also a lot deeper and harder to find. I've noticed that on obese patients, a lot of times they have like fat deposits in their antecubital area, which kind of trick you. They almost feel like veins, like they're squishy and they have like a patency of like a vein. So a lot of times in obese patients, if I don't feel like super comfortable with their antecubital area or they've got a lot of fat in that area, I'll just go to the back of their hand. I know it hurts a lot more. A lot of bigger patients will actually come in and just say, go straight for my hand because, you're going to poke me 5-6 times in the AC and never get anything and end up going to the hand anyways. Let's just start out there. So that's usually what I'll do if I'm not having any luck in the antecubital area. I don't think I want to say anything else about that. Okay, so paralysis. You want to avoid drawing blood from a paralyzed arm. There's an increased chance of clotting in that arm, and it's really difficult to detect nerve injury as the patient can't feel anything in that arm. So pretty much all I want to say about this is an arm that's lost muscle function, which is what a paralyzed arm is, has also lost the muscle action that returns blood to the heart. So that's why blood flow is more stagnant in that arm, and it can cause vein thrombosis, which can cause erroneous test results because of hemoconcentration in that area, etc., etc. So if a patient has a paralyzed arm, just avoid it. Don't draw from that arm. If both of their arms are paralyzed, like they're paralyzed from the neck down, I mean, you don't really have much of a choice because we are definitely not going to draw from their neck. So, like I said, in situations of a double mastectomy or paralysis of both arms, they're most likely going to have a doctor's note telling you where to draw from. But if they don't, either contact the physician or use your best judgment. There are some cases where like patients that have been coming in for years and getting drawn every month for 10, 20 years that are paralyzed. There's older phlebotomists in the lab that have been there for longer and they know where to draw them from or they've seen the physician's note, so they don't need to bring it in every time. But just use your best judgment. Okay, so I'm going to stop the lecture here, and then we're going to continue with vascular access devices, which might be a more difficult concept to understand, but we'll get through it.